If you or your child has scoliosis, you may have been told there's nothing to do at this point except to watch and wait. Or maybe you've been told you can do bracing, but you can't really reduce the size of the curve. You can only hope to keep it there or potentially slow the progression. Or possibly you've been told that at this point there's nothing you can really do except surgery. The reality is those are likely old school methods of thinking, and it's still advice that's typically given today in many orthopedic centers. But in 2026, there are many newer and more modern treatments and more modern approaches to treatment. Hi, I'm Dr. Chris Skubels, the head clinician here at ScoliCare Denver and leading authority in the non-surgical treatment of scoliosis. And in this video, I'm going to help you better understand what scoliosis is, what causes scoliosis is, and what are the best and most effective modern scoliosis treatments. Now, if you or your family member are watching this and at any point in time you want to know exactly what's going on with your scoliosis and what can be done for it, just click on that link below and request a free discovery call, and that'll give you a chance to talk to me one-on-one about your scoliosis, the severity, how likely it is to progress, and what treatment options you are a candidate for. Now, what exactly does cause scoliosis? When we think about scoliosis, especially in children or adolescents, which is teenagers, 80% of all those cases are considered idiopathic, which is a big fancy word that basically means we don't know exactly what causes it, but we know exactly how it progresses when it does start. Idiopathic scoliosis is likely a genetic condition, and there's probably multiple genes involved. And we don't know exactly what trigger those genes, whether it's environmental or hormonal. It's probably multiple factors that trigger the genes, but it causes part of the bone to grow slower and part of the bone to grow faster. And that abnormal or asymmetrical growth causes the spine to twist and rotate. So scoliosis is a lateral bending of the spine with rotation. And so for someone to be diagnosed with scoliosis, they must have at least 10 degrees of lateral bending when measured using the Cobb angle of measurement, and there must also be rotation present. That's the idiopathic scoliosis. That's the 80% of all those when scoliosis is diagnosed in children or adolescents. But what about the other 20%? What are potential causes of those? There are several potential other causes. There's congenital scoliosis. A congenital scoliosis actually develops during in utero when the baby's developing. And it's when the bones actually deform abnormally or grow abnormally. You could have what's called block vertebrae, where several of the vertebrae are actually connected together. Or maybe you get a hemivertebrae, where a vertebrae doesn't form fully. Or maybe you get a wedge deformity. Many different things, but the bones actually grow deformed in utero or where the baby's developing. You can also have neuromuscular scoliosis. These are scoliosis that are secondary to neuromuscular conditions such as muscular dystrophy or possibly like cerebral palsy. And then some scoliosis are also secondary to other conditions. This could be to like connective tissue disorders like Marfan's or Ehlers-Danlos. And then I even had a few that are secondary to like a neurological trauma, possibly due to a tumor, cancer. And just today I had one from a condition called osteogenesis imperfecta, which is basically when the bones can easily break. In this case, the spine was actually compressing under the weight of gravity. Now, when we think about scoliosis in adults, typically we have one of two things. We have someone that had scoliosis when they were younger, that they still have an adult, and the majority of those cases continue to progress in adulthood and become degenerative, or you can have scoliosis that actually develops in adulthood. This is typically called an adult degenerative de novo, meaning a new scoliosis in adulthood. Now, adult degenerative scoliosis or de novo scoliosis typically begins in women around 50 with the onset of menopause, where you have a change in bone mineral density, and as estrogen goes down, you also get a change in connective tissues, or in men typically a little bit later on, like around 70 or so. And then some adults, you can have scoliosis that's secondary to more a neurodegenerative condition, something like Parkinson or Alzheimer's. Now, let's first talk about what are the traditional orthopedic recommendations when we're talking about, juveniles or adolescents, basically children or teenagers. They're generally pretty conservative. So for anything under 25, there's not generally any recommendations. That's where they recommend watching and waiting. Now, we're not a big fan of watching and waiting. If for smaller curves, we like to do more what's called active observation, where we're doing regular scheduled checkups at least every 6 months. Now, for curves between 25 and 40 degrees, they'll typically recommend rigid bracing. But they'll tell you that you can't reduce the size of the curve. You can only hope to slow down or stop the progression of the curve. And I believe that is true with the types of braces they use, such as the Boston braces. Because the braces they use are not truly customized in a three-dimensional way. They actually use what's called 3 points of pressure, where they try to squeeze the brace and just hold it there. But for anything over 45 degrees, that's when they typically recommend surgical intervention. Now, what's interesting is I've heard some prominent people in the orthopedic world recently even talking about how their recommendations are probably outdated. And in the orthopedic world, they probably need to start exploring treatments earlier on before they hit 25 degrees. And they probably need to even consider doing some non-surgical treatments for larger curves beyond 45 degrees. But today, these are still the recommendations that are given at almost all orthopedic centers and hospitals. There's a few big problems with those treatments. First of all big curves start off as small curves. And the earlier we catch these and the earlier we intervene, the better the overall outcome. And on our viewpoint, and on my viewpoint, there's no reason to let a spine get bigger and get more deformity in it before you start treating. Because as the spine gets bigger, the bones grow more and more asymmetrical, and there's more deformity. And the bigger the deformity gets, the more difficult it is to treat. So if we know there's a scoliosis developing and it's in a smaller curve with a lot of growth, telling us there's a lot of risk or a high risk of curve progression, in our viewpoint, there's no reason to wait to treat. There's things we can do earlier on. At least give parents the option to do things earlier on. There's always what's considered a scope of acceptable treatments, from like the bare minimal acceptable intervention to the most extreme. So in our viewpoint, there's no reason to wait for curves to hit 25 or 40 degrees before you start to do something. Also, in the real small curves, we like to actively be checking those every 3 to 6 months, not really watching and waiting, which a lot of times there's not an exact routine checkup, and a lot of times things can go from small to big before anything's done. Also, even in those larger curves, there's a lot of times things we can do to reduce the size of the curves before surgery is needed. We've had multiple cases. We have a whole case series here at ScoliCare where we've treated curves between 45 and 60 degrees, where we've got those down below the surgical threshold and where surgery was no longer recommended. Even in adults, in smaller curves, we can still do treatment. Most of the research on adults is on adults over 60 years old, where the curves have gotten more severe and they're pretty degenerated. And the research still shows that we can be effective at treating those with custom bracing and scoliosis-specific exercises, but the research also says even though we know we can be effective at treating adults with more severe curves, we'd be better off treating them when they're younger and more flexible because we could change the future of those. That's one of the problems with scoliosis treatments in orthopedic centers. It's very reactive versus proactive. But if you think about other health conditions, if someone was pre-diabetic or they had hypertension or they started to develop hyperlipidemia, high cholesterol, they wouldn't just wait to do something. They would jump to recommended medication to lower those. So it's a little bit odd we're so conservative at starting with conservative treatments. I would say at ScoliCare, we are more aggressive at being conservative, where I think in the orthopedic world, they're more aggressive at doing more severe things or invasive things like surgery. The reality is the best treatments come by getting the right treatment at the right time. And although we can treat curves when they're larger, the best opportunity for the most effective treatment comes earlier on when the curves are still smaller. Now let's dive into more modern scoliosis treatment recommendations. So this goes through some different treatment recommendations. Anything below 10 degrees, we're just going to do active monitoring. But once we hit that 10 to 20 degree window, that's when we can start doing things, anything from scoliosis-specific exercises or potentially part-time or nighttime only bracing. Once we get a curve between 20 and 45, that's likely when we're going to be doing scoliosis-specific exercises and custom bracing. The one caveat on this, it really depends on the risk of curve progressing. So if we have someone that's younger, we're going to say a juvenile or an adolescent that's anywhere from RISR 0 to RISR 2 or 3, we're going to be doing full-time bracing and scoliosis-specific exercise. But if we have an older adolescent or teenager that is almost done growing, or maybe a young adult, that's when we have the option of possibly doing just scoliosis-specific exercises or bracing, and we may not have to be as aggressive depending on the patient's outcome. But even in an older teenager or a young adult, if they want to try to reduce the curve, we're still going to do those full-time bracing and scoliosis-specific exercises. And when a curve is between 45 and 60 degrees, we still have evidence to show that we can effectively treat those with custom bracing and scoliosis-specific exercises. But once a curve gets beyond 60, that's when someone has become surgical. Even at 45 to 60 degrees, we will frequently recommend at least a surgical consultation so they know what's on the table, and generally treatment is not effective if they're not compliant with the treatment. We don't have very many people, in fact, I haven't had any patients that came in with curves between 45 and 60 that were compliant with treatment and were not also successful. Over 60 degrees, we don't really have any evidence to show that conservative treatments are effective at treating those, and that's when we know someone is definitely a candidate for surgical intervention. So let's review what the modern non-surgical treatment options. One, scoliosis-specific exercises. Now, scoliosis-specific exercises are different than traditional physical therapy. There's a few different methods of scoliosis-specific exercises out there. A really popular one is something called Schroth. Schroth is one of the oldest methods out there, and it's really well known for what's called rotational angular breathing. Some other methods are what's known as SEAS, the scientific exercise approach to scoliosis. There's the side shift method. There's something called chiropractic biophysics, and also something called CLEAR. Now, all these techniques have some really good things and some positives, but I think some of them have some flaws that are missing some key or important components too. So at ScoliCare, we use a newer, more modern method called ScoliBalance. And at ScoliBalance, we combine several of these methods: Schroth, SEAS, chiropractic biophysics, and we decide what's best for each individual patient, and we take different parts from these various methods, and we'll use whatever is the most appropriate and whatever will be the most effective for each individual patient. But there are 4 criteria that need to be incorporated for something to be considered a scoliosis-specific exercise. The first criteria is you have to teach the patient how to put their body in a 3-dimensional correct position. Number 2, you have to strengthen and stabilize them while they're in correction or in their correct position. 3, you have to incorporate activities of daily living. Basically, you have to teach the patient how to put themselves in a 3-dimensional correct position and to hold that while they're doing things they already do in their everyday life. And 4, there's a education involved. The patient has to really understand what's going on with their spine to know how to be involved in properly treating their individual scoliosis. Now, the second non-surgical modern scoliosis treatment is true 3-dimensional custom bracing. Bracing that actually puts the spine in a correct or over correct position, and it's individually customized and tailored for that patient, and it actually has a 3D rotational component, not just trying to squeeze the spine. This is what the Scoli brace is, which I believe is the most advanced, most modern, most aggressive, and most effective brace currently available. And then the last thing is combining scoliosis-specific exercises or rehabilitation and custom bracing typically gets the best and most effective results. So what about when someone is beyond the scope of non-surgical treatment options and they require surgery? There's a couple of prominent surgical methods out there. And one of those is something called vertebral body tethering, where it's actually a non-fusion type of surgery. This is typically only effective in smaller or more flexible curves. Even people with larger curves and stiffer, more rigid curves are not typically a candidate. This is also still considered a bit experimental, but the nice thing is it does preserve movement and it doesn't fuse the spine. Basically, they're putting in screws into the vertebrae that influence how those vertebrae grow, trying to guide them to grow more symmetrical. Then it has cords that actually run along the spine to also assist in putting the body in a more correct position. For larger curves, more stiff, more rigid curves though, that's when we do spinal fusion. And I have had patients that needed spinal fusion. I actually had a call yesterday from a patient that was beyond the scope of conservative treatment, and I told them that they really had to do spinal fusion. And when a curve definitely needs surgery is typically when a curve gets beyond 70 degrees, that's when it can impact lung function and breathing. And someone beyond 70 degrees absolutely needs to look into doing spinal fusion surgery. Now, let's talk about some of the adjunctive treatments that can be done along with scoliosis-specific rehabilitation or bracing. One of those is chiropractic care. Chiropractic care can be really good at reducing pain and keeping the spine moving. You see, when scoliosis develops, the spine starts to twist and rotate, and that changes what's called normal coupled motion patterns. And when you change normal coupled motion pattern, the spine immediately starts to stiffen. Chiropractic adjustments can be good at relieving pain in adults or even juveniles with pain, but it's also really good at putting mobility into the spine. And the more flexible and the more mobile the spine is, the higher the likelihood or the easier for potential correction. Things like massage, acupuncture, yoga, those can also be beneficial to the patient because they can help reduce pain, they may help improve mobility, and all these things have a lot of other potential health benefits too. We just know these adjunctive treatments can't really change the likelihood of a curve progressing, and they can't make curves better, but they are often recommended and can be used in conjunction with scoliosis-specific rehabilitation methods like ScoliBalance and ScoliBrace. So let's do a recap on some of these key takeaways. 1, scoliosis is a 3-dimensional spine deformity, and it needs a 3-dimensional treatment to be most effective, whether that's with 3-dimensional corrective rehab or 3-dimensional bracing. All big curves start off as small curves, and the timing of intervention matters. And the earlier we can start intervention, the earlier we can start treatment, the more effective the treatments and the better the overall outcomes. There always is a window of opportunity for the most effective treatments and the best possible outcomes. Watching and waiting has its limits. At a minimum, you should be doing active observation for smaller curves. And for larger curves, there's no place for watching and waiting. And each patient is different, each scoliosis is different, and each treatment needs to be individualized and customized based on that patient-specific scoliosis, its cause, its risk of progression, and the patient's individual goals. Now, if you have scoliosis, you're probably wondering what your next step is. And that could very well to go in and see a specialist on scoliosis treatment. Now, if you're not sure what to do or what options you do have, you can always click on the link below and request a free discovery call. That'll give you a chance to talk to me one-on-one about your scoliosis. I'll let you know the severity of your scoliosis, I'll let you know the risk of your curve progressing, and what treatment options I believe you're a candidate for. Now, if for any reason I don't believe you're a candidate for the treatments we do at ScoliCare, I can also let you know what I do recommend. But if you're ready to take that next step and you want to come into ScoliCare and see if we can help you, reach out to our office to schedule that initial evaluation. Now, if you want to learn more about ScoliCare and what we offer, click on our next video and I'll see you there.